Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jeanne Sarnosky, and on today's program we're going to learn a little bit more about diabetes management, and we're lucky enough to have with us today Debbie Allietta, who's a diabetes educator for the Visiting Nurse Association of Cape Cod. So thanks, Debbie, for being here. I appreciate your time.
Thank you for inviting me again, Jeanne.
Sharing all your wisdom.
Yeah, we'll try.
Yeah. Well, I like for the viewers to get to know our people first a little bit. So tell us, how long have you been with the VNA?
Well, actually, believe it or not, we go back to 1975 when I started with the VNA with the little blue bugs, and I was a part-time then. And then I took a few years off, of course, to have children. And then along the way, I came and I went, and I came and I went. But this stint has been 10 years. So I've been a diabetes educator for 10 years here.
Wow. So why this? It wasn't exactly a switch. It was just further development of your nursing background.
Right.
But was there a curiosity, or did you have a family person with diabetes? Or?
Actually, diabetes and cardiac disease were my two favorite areas of interest in college.
Oh, wow.
And I worked for the congestive heart failure program at Cape Cod Healthcare, and then they ended up closing the program. So my second option was, well, maybe I'd like to get into diabetes, and that's why I began looking into that.
And there's a lot of it out there.
Huge.
Yeah. Is there more here like Cape Cod than the national, or are we sort of the same as everybody else? You know why
Cape Cod is unique? Because of the number of elderly people.
Okay.
Because there's many risk factors involved, but being your age is certainly a risk factor, and we have so many retired people here that yes, I think it's like Florida. There's a huge incidence because of the number of elderly, but it also affects other age groups as well, not just the elderly. But I don't know statistic-wise, but across the United States is about almost 27 million people have diabetes, and that actually, I want to say probably every 6 to 8 months at least, the statistics tend to go up. Now, the Centers for Disease Control, who do a lot of the town and city statistics, don't do them every year. They do them every few years. So, but the estimate from the American Diabetes Association at this current time is 26.8 million. And then 79 million have prediabetes, which precedes diabetes in all cases, actually.
Oh, wow. I think it seems to be a more familiar term, diabetes, and disease just as a discussion. So it must be getting more exposure, greater education into the hands of consumers.
I think it is much more of an, if you will, accepted disease.
Maybe,
where years ago, I go to some patients' homes and people will say to me, oh, my grandmother had it, my mother had it, but I never knew. They'd go in the bathroom to do their injections, or they didn't want to tell anybody, or we could never talk about it. So it kind of had a stigma to it. I think now with education, I think people are getting much more of an idea of what it is and how great of a problem it actually is.
Right.
And that it's the same as any other disease. It's a disease process within the body, not the person's fault. And it's just one of those things that we have to learn how to manage.
Right. So that opens the door to what types of diabetes are out there?
The main types are type 1, which is usually seen in children, even in early adolescence, usually under the age of 30. Type 1 is an autoimmune disease, like some of the other autoimmune diseases where the body attacks its own cells. So type 1 diabetes, the body has attacked the beta cells of the pancreas so that the pancreas can no longer make insulin. And insulin's role is to transfer the glucose from the carbohydrates that we eat into the cells of the body for energy. So if there's no insulin, the blood glucose levels get very, very high, and it can be life-threatening. Type 2 diabetes, which is the majority of people that have diabetes, about 95% of people with diabetes have type 2. Only about 10%, or not even 10%, have type 1. So type 2 it can occur at any age, but typically they say it occurs over the age of 30. However, we are now seeing a lot of young children, adolescents, in certain ethnic groups with type 2 diabetes, where years ago we never saw that either. And in type 2, there's a lot of risk factors involved, but what happens is the pancreas is still making insulin, But because of what's happening in the body with the diabetes, the insulin is in lesser amounts and it's not able to do its job. Then the third type we see is gestational diabetes, and that typically occurs when the mom, it's diagnosed about 24 to 28 weeks of pregnancy, and it's the hormones that the mom makes for the baby to develop that cause her to not be able to use her insulin effectively. Usually goes away after the baby's born. However, sometimes there's a greater risk for mom to develop a type 2 diabetes within 10 years. There's also a risk for the baby to develop it sometime in its lifetime.
Wow.
Yeah.
And is that another one of those genetic predisposition for gestational?
It's interesting. Yes, can be. Now, some moms, some gestational moms may have 4 pregnancies and only have it with 1 pregnancy.
Oh, yeah.
We just don't know. Diabetes is still a science that we're learning a great deal about. We know a lot about it and have learned a lot, but there's still some intricate details that we just don't really quite understand why. But certainly if somebody has diabetes in their family, that's a risk factor to begin with, a huge risk factor for all types of diabetes.
Okay. So if we look at genetics or lifestyle, you probably get that question a lot. So that first 10% that you mentioned of the type 1, that's definitely genetics.
Well, it's genetics in the sense, genetics basically means is you inherit a gene from a family member. Type 1 definitely has some genetic components to it.
So no guarantee.
No guarantee. Like there could be identical twins and one might have it and one might not, which we don't understand why. But genetics definitely plays a role in the beginning. I just saw a young boy the other day up in Carver, and his biological dad had type 1 diabetes. So his mom is now remarried, and she has a very good familiarity with it because of living with him with it.
So type 1 or type 2 could be genetics.
Could be genetic. And absolutely there's probably a genetic component with gestational as well. I have to applaud Dr. I can't think I remember his name. He used to be an endocrinologist here in Falmouth years and years ago, and he always would say this one quote that I love, and it really sums it up, is that genetics loads the gun, but lifestyle factors pull the trigger. Dr. Coughlin. Oh. So genetics
That's a good way to think
predisposes the pancreas to begin to malfunction, whether it's in type 1 or type 2. Lifestyle factors are involved with type 2 more so than type 1, meaning being overweight, sedentary, eating unhealthy. Those things kind of dictate when and if that person will develop type 2 diabetes.
Okay. So lifestyle, big importance in how it's managed.
Huge.
Also for prediabetes, lifestyle?
Yes, actually prediabetes, we know that prediabetes means blood sugars are higher than normal, but they're not yet at the diabetes range. And we know that prediabetes can actually go away if it's identified early, if the patient has education about losing weight, exercising, and changing the way they eat. That can really have an effect on lowering blood sugars, getting them back into the normal range so that the prediabetes may not go on to type 2 diabetes. What's happening is that over the years we didn't know a lot about prediabetes, so people were not identified early on and they went right into type 2 diabetes without knowing it.
Right.
Now, lab slips are flagged with numbers that are in the prediabetes range, telling the physician that this person has a difficult time with the potential for developing type 2 diabetes. And my prayer is that physicians will pick up on that, educate the person to try to let them know that this can go into type 2 diabetes, but it doesn't have to.
So they could stay pre-diabetic for years and years years and never cross over into type 2?
Absolutely, they could. Okay. Absolutely.
Are all type 2s, could they have been discovered, or were they pre-diabetic at some time? Or
Yes, yes. Actually, what happens in the whole stage of development with diabetes is, and this is where, again, the genetics predisposes the pancreas to fail. But being overweight interferes with the action of insulin. Being overweight causes visceral fat to surround the organs, which secrete these really dangerous and unhealthy chemicals in the body that affect the way insulin is produced and the way insulin is used. So that puts a strain on the pancreas. So what the pancreas says in its little brain is, you know what? it's not working properly. Maybe if I make more and more and more insulin, I can overcome the default that's not working properly. But then what happens when something is strained above what it can actually do, it ends up pooping out. And at that point is when type 2 diabetes actually develops. Prediabetes means there's some things not happening that should be happening. The pancreas is strained, the pancreas is not doing what it should do, the insulin is not doing it. But if it's picked up early on and the person can make lifestyle changes, oftentimes that can go away or not go on to type 2 diabetes. And another thing that's really important, Jeanne, that we've learned over the years with diabetes is now we know that even in pre-diabetes blood sugar levels, there are already cardiovascular changes, there are nerve changes, kidney changes, eye changes that are going on, even when blood sugars are not in the diabetes range, but they're higher than what they should be.
So when the blood sugars are higher than what they should be, and they could be flagged pre-diabetes, they're already affecting all those other organs.
Absolutely. And the longer somebody has pre-diabetes without being diagnosed, the more potential for those things to happen.
It seems an easy diagnosis if it's just flagging the blood sugars.
It is if people go for the recommendation by the American Diabetes Association is that everybody at age 45 should have a fasting blood sugar. If they have diabetes in their family, yearly they should be checked. If they don't, every 3 years. But I'll speak for myself. Until I got into my late 50s, I didn't go to the doctors unless I was sick because fortunately I was healthy. So and my dad has diabetes, so shame on me. So I probably should have been going more frequently, but still. So what happened is a lot of people don't go to the doctors when they're in their 30s and 40s and 50s because they don't feel bad, you know. And with diabetes in the beginning, you don't have symptoms, so you don't know that you have it. You don't, like you have bronchitis, you have a bladder infection, or you have, the flu. You've got something going on. You go to the doctors. You don't get symptoms early on, so people don't know unless they're being seen on a regular basis.
So what would the recommendation then be if you have family history? Certainly by age 30, at least have a blood panel done. So you have a baseline somewhere?
Absolutely. I mean, I would recommend it. I have children. I have 3 children that are in their 30s, and I've had all of them checked for diabetes. And I told them, I really want you to do this every few years just because it is in my family. And my children are healthy, but you just don't know.
Right. Is it an automatic if someone has a physical and they do a regular lab screen? Is that automatically included in that panel?
Yes, it is. It's called, and I don't know what the exact name is, a BMP, it's some particular name, but yes.
It's not something that needs to be added or asked for.
No, it's part of it. Fasting blood sugar, just like they do your lipid levels, they do your liver function, your kidney function. It's part of that panel.
Okay.
Right.
So if one is pre-diabetic, and you had mentioned they would not even necessarily recognize any of the symptoms, what would symptoms be when they do show up?
Okay, so what happens when blood sugar numbers are consistently high, and everybody's different, so I can't give you a number that says, okay, at 200, this is what happens. But typically what happens is our body, every area of our body knows what's healthy and what is unhealthy, so it tries to compensate for things that are happening. The kidneys know that extra sugar in the bloodstream that they're trying to excrete is not healthy, and they know when there's large amounts of sugar that the way to get rid of it is to make the person urinate more frequently to get rid of that sugar. So that's what happens, is increased urination. Well, the more we urinate, we become dehydrated. So then there's thirst. So those are 2 really, really key symptoms.
Wow.
Fatigue is another huge symptom, but hard to recognize because we all know, especially as we get older, we tend to be more tired than we used to be.
Why am I
But the glucose is in the bloodstream rather than in the cells of the body because insulin is not doing its job. So the person's very, very tired. Slow wounds, wounds don't heal well with high blood sugar numbers. People might have vision changes. They might have numbness and tingling, which is early signs of nerve damage to their feet. So they may have all these symptoms, but it's easy to poo-poo symptoms away if they're not severe.
Yes.
It's easy to rationalize in our mind. Well, and the other thing is a lot of elderly people, the symptoms of early diabetes mimic the aging process. The frequency of urination, the fatigue, the eyesight, so they may just say, you know what, it's just because I'm getting old, and just not think about it.
Yeah. So the definitive testing is a blood test. All right.
Absolutely.
So if they have concerns,
So the numbers are normal fasting blood sugar is 70 to 99 milligrams per deciliter. Prediabetes is 100 to 125, which is a very small window.
Yeah.
Greater than 126 is diabetes, and it's recommended that it should be checked a second time just to make sure that there was no error. I've had patients when I go to their homes to see them say, they got my blood mixed up with somebody else's. I know I don't have diabetes. So I'll say, well, ask your doctor to do another one.
And then you see them next week and say,
Yeah.
I thought so. Now this is what
Well,
we
I
have to
just
do.
play the game with them.
Yeah. So obesity plays a big role.
Yep. It's not the cause of it, though, because we see a lot of obese people that do
don't
not
have
have
it.
diabetes.
So if one is pre-diabetic or also are already known to be diabetic, diabetes type 2,
Yep.
say, and they are obese, losing the weight can help?
7%, losing 5 to 7% of their body weight can help their body use their insulin more effectively.
That's not that
and
much.
that is not. If you look at a 200-pound person, you're asking them to lose 10%, that's 20 pounds. So it's not all that much, even
Right.
though we know it's hard to lose
20
weight.
is a
It's
lot,
not
yeah.
easy. But yes, if they can lose weight, their insulin is going to be used. The pancreas is not going to be strained as much because the pancreas is not going to say, I got to produce more and more insulin to do the job. So it's going to take the strain off the pancreas, and it's going to lower blood sugar numbers. And oftentimes in the beginning, if blood sugar numbers aren't very high, the doctor will say, okay, go to a dietitian, learn about changing the way you eat, join a gym, get involved in exercise, lose some weight, come back and see me in 3 months. And sometimes just those lifestyle changes are enough to get their blood sugars back to where they should be.
So they wouldn't necessarily
go on to. Now, if it's diabetes, if they're 126 or greater on 2 occasions,
Yes.
they can eventually control those blood sugars by lifestyle and or medication to where they're normal.
Yep.
But if they stop those medicines or went back to their old lifestyle, the
Right.
numbers would go right back
So
up.
what else in lifestyle? So it's weight,
Exercise, and changing the way you eat.
And changing the way you eat.
Eating smaller amount of carbohydrates and certainly taking in less calories so that you
which
will
affects
help
the
lose
whole-
weight.
Right.
It's a vicious cycle.
So that must be reassuring for people that maybe that don't want to deal with the insulin, that they can be reassured that they could, with the right motivation and compliance, maybe get off it.
They can, Jeanne, but what we know about diabetes is it's called a progressive disease.
Okay.
And what that means is the pancreas over time continues to fail. It's estimated from studies that have been done on the insulin production of beta cells that a person at diagnosis has probably already lost about 50% of their beta cell function. So the pancreas is only working at 50% efficiency. Every year, they lose about 4% after that.
So the damage has been done?
So the damage has been done, regardless of what they do. And that's not to say we want them to just continue with, and say, well, forget it, because they're going to develop the complications.
Right.
But certainly, they need to understand that this is why insulin is usually inevitable for everybody with type 2 diabetes at some point, depending on how long they've had it, because the pancreas, you say, so if you lost 50% at diagnosis, another 5 years, it's another 20%, that's 70%, another 5 years. So by 10 years, you've already lost 90% of your pancreas function.
Yeah.
So, and if the pancreas can't produce insulin, you have to get it some other way. So that's when you're going to have to take it, exogenously by a violent syringe or an insulin pen or an insulin pump.
Okay. Now, long-term complications?
Long-term complications are preventable. However, the longer one has had diabetes and the higher blood sugar numbers have been over time, the greater the risk of the complications. And I mentioned some before. It can lead to blindness, retinopathy. Diabetic retinopathy is the #1 cause of blindness. Renal failure. Diabetes is the #1 cause of kidney failure. The blood vessels in the kidneys fail to function because of the high blood sugar levels. Heart attack and stroke are much more evident in people that have diabetes. Neuropathy is damage to the nerves, numbness and tingling, very uncomfortable condition that causes a lot of problems for people walking and sleeping and that kind of stuff.
Yeah.
So it affects every part of the body, the high blood sugar numbers do.
So the targets that are established for people.
Okay, we talked a little bit about the prediabetes and where those numbers come in, okay? The prediabetes, we already know that they're starting to develop some of the early complications. So there were two huge landmark studies. One was done on type 1 patients, the Diabetes Control and Complications trial. These went on for about 10 years. Thousands of patients, and then the other one was done on type 2 patients. It was called the UKPDS trial, which was very similar. Two groups of patients. One group kept their blood sugars all within a very good range over the 10-year time. The other kept their blood sugars all out of that range for the 10-year period of time. There were 30 to 60% less complications in the group that kept their blood sugars. And the blood sugars, that's under 150. So that's where they come up with the targets, and that is why, too, we've lowered the targets. It used to be, and I'm dating myself, but when I was in college in the 70s, normal fasting blood sugar was 80 to 120. Well, now 120 is just about diabetes.
Yes, too high.
Because we now know that between 100 and 125, there's already complications developing. So they set these standards according to what the results of their studies were.
Wow. And a 10-year study is a valid study.
And there were thousands of people involved in it.
What is diabetes self-management? Is that the eating and the exercising and the...
Well, you mentioned disease management earlier. Disease management means that we have to come up with a system that helps the person manage whatever chronic illness they have. It could be emphysema, COPD, asthma, it could be hypertension, heart failure. Diabetes is huge as well. So what's that diabetes self-care is that we got to help the patient to identify the areas in their life that are interfering with them managing their diabetes effectively. And what that means is we want their glycemic control, which means their blood sugar numbers to be in a healthy range, be within target to prevent those complications of diabetes. So the self-management is, and one of the things that my organization, the American Association of Diabetes Educators, has developed is they're called 7 self-care behaviors. And what they are monitoring blood sugar, healthy eating, taking medication as prescribed, being active, reducing risk by having certain tests done every year to make sure that you're not developing the complications of diabetes, healthy coping. Coping is hard with diabetes because it's a disease that doesn't go away. It's a 24/7 job and can be really debilitating and depressing for a lot of people. And problem solving. So we want to help the patients to learn what is happening. Why are their blood sugars going up? Why are they going down? What can they do about them? So with these self-care behaviors, not everybody needs help with every one of them. Some people have had diabetes for a long time and they're just struggling with maybe healthy coping. Maybe they do a really good job managing their blood sugars and checking the blood sugars and eating healthy, but they're really struggling with coping with diabetes. So we help them to identify what is going on. How can we help them to make the changes necessary to improve their glycemic control?
Great, huh? Wow. Big difference for people.
It's huge.
You know, we only have a few minutes left. I think it goes so fast, right? So I just want to make sure we cover some of these. That you had mentioned the depression and keeping people motivated. Any other highlights that you want viewers to be aware of within the system? There's certainly the outpatient education program.
Yes, there is the diabetes education, the outpatient diabetes education program through Cape Cod Healthcare. There's they have classes in Falmouth and Hyannis for any patient with diabetes if they have a diagnosis of diabetes. They don't cover prediabetes, unfortunately. You would think they'd cover prevention, but right now we're not there. And those classes are excellent for patients for just giving them education. Maybe they need ongoing support because, again, diabetes is a 24/7 job. And most people that I go to really struggle if they've had it for a long time, especially if they have the complications. Because we may be asking them to check their blood sugars 2 or 3 times a day, taking medication, maybe insulin, watching what they eat, counting their carbs, being active. So we're asking them to do a lot of things. And we know as we get older, lifestyle changes aren't easy.
Yeah, Yeah. Is that the average? Checking 2 or 3 times a day? Is that
Depends on some
everybody's
patients.
different?
Yeah, everybody's different.
Yeah.
Some patients only check once a day. Depends on how many medicines they're on. Depends if they're on insulin. Depends how they take their insulin. So everybody. That's a really good point, Jean, that you made. Is diabetes has to be individualized, because if you had it and I had it, neither one of us would be the same. Our blood sugars wouldn't be the same. We might have different needs. So we need to individualize it for each person.
And really good for people to know that help is out there.
It is out there.
And if they have any family history,
they should be very diligent with being checked, making sure that that they're not developing it.
And it's a simple blood test.
It's a simple blood test.
Yeah.
Yep. Fasting blood sugar.
Yep. So if you sort of behave ahead of time, maybe we can.
And let me just clarify one thing too. People that monitor their blood sugar with glucose meters, that can't be used for diagnosis. It has to be a venipuncture. The blood has to come from the arm. It can't be, because there's a variability factor in glucometers. Oh, yeah. So you could check if you're on all 10 different fingers and get a little different reading.
Yeah.
So it's got to be done by a venipuncture.
All right.
Just to clarify.
Good to know. All right. Thanks, Debbie, for being here and
Jean.
sharing your wisdom again. I appreciate it. Good information, really.
Thank you very much.
Good. All right. I'm Jeanne Sarnosky, wishing you good health and good health care.